have Dr. Cornelia, and we have Mariam, who will also be speaking to us about the same, on how to implement at program level and what kind of results that we have seen as a program. So I'd like to stop there and request David to take it away.
David, can you hear us? As we're getting David on board, and he's not able to hear us, or he's just dropped off. So as we're getting him on board, maybe we can go to the next our next presentation by Dr. Cornelia Ochola. She's the Senior Technical Advisor at CHEB. At CHEB, she's a pediatrician and public health specialist with over 5 years experience in pediatric and adolescent HIV programming and has interest in maternal and child health. Dr. Ochola, we welcome you to give your presentation as we get David on board.
Kindly stop sharing. Good afternoon, everyone. Can everyone see my slide?
And thank you.
Yes, we can.
Thank you. So my name is Dr. Cornelia Ochola, as has been said, and I'll be making a presentation on OTZ Plus implementation in PMTCT in the CHEB Connect program. So CHEB Connect supports Nairobi County in 65 care and treatment facilities, 51 PMTCT facilities, and we also support other program areas in HIV service provision, that is TB, medical assisted therapy for people who inject drugs for the key population, and also we have DREAMS for the adolescent and young girls. And this map just shows our distribution across the county. So a brief background on how OTZ Plus began in CHEB, and generally just in the HIV program. So as I had mentioned, CHEB Connect supports 51 PMTCT health facilities within the Nairobi County, with approximately 4,000 to 4,500 PMTCT women on follow-up. The facilities support PMTCT women in the informal settlements, mainly informal settlements, and am I audible? I hope my network is not misbehaving. Hello, can you hear me?
Yes, we can hear you clearly.
Sorry, apologies, my internet interrupted. Yes, so we've noticed that there has been an increase in teenage pregnancies across the country. We noticed during the COVID-19 pandemic, when it was at the peak of it, when children are not going to school, there was quite a bit of increase in teenage pregnancies at that time. And we've had, that has been there for a while now. However, early intervention, just to ensuring that we're able to get intervention that support our adolescent girls and young women were missing, especially in our PLHIVs. Remember, for the PLHIVs, they, who are adolescent girls and young women, they present with unique characteristics, such as, for example, when they have early pregnancy, they need to drop out of school. At that point, there are family issues, and sometimes they have difficulty just to fit in with the older mothers who are attending PMTCT. And as we had discussed about OTZ about 2 weeks ago in this same webinar, you find that now they're also not able to fit into that OTZ because now they're pregnant, maybe they're not yet, they're not comfortable with that particular situation as how they are. And also they're feeling judged by their fellow adolescents. So you find they have difficulty fitting into this. And also we lack messages that target these young mothers, because most of these messages are just similar to all that are passed for the older population. So these are some of the characteristics that we notice in this particular adolescent girls and young women, and thought that probably having something that is like OTZ with good outcomes would be able to also affect these particular adolescent girls to ensure that they also get good outcomes. And what we noticed in our program is that we have about 40% of our pregnant and breastfeeding women who attend FAST ANC are actually adolescent girls and young women of the age 10 to 24. And this led to the formation of these young mother support groups, the OTZ+.
Thank you.
Someone is speaking, kindly mute. Thank you. So what were the gaps that were identified when supporting pregnant and breastfeeding women? This who are adolescent girls and young women. We noticed that in this particular population, there was a knowledge gap in sexual and reproductive health. There was also a skills gap. So they were not able to navigate through their personal relationships. And they're also disadvantaged when negotiating for safe sex practices. There was also people who are having access to family planning services. There were skills gaps also in the healthcare providers in supporting the PMTCT adolescent girls. As we all know, in our culturally, most of these girls are looked down upon. So there was stigma and discrimination at home, in school, and also in the facility. And also, as I had mentioned before, there was lack of a structured focus support group, just targeting these adolescent girls and young women who are either pregnant and breastfeeding within the PMTCT setup. And so there was, and also as you notice, the rights as PMTCT adolescent girls and young women were not really being met. And so these are some of the gaps we noticed as we were beginning the OTZ Plus program. So we were looking at interventions that were going to answer to these particular gaps. And so the birth of OTZ Plus. So I'll just come in and just be able to share just the distribution of adolescent girls and young women in all our facilities, looking at the months of from October to March 2022. So in the last 6 months, we've had about 9,330 pregnant women attending the ANC. And this is entire population, not only the adolescent girls. And of this, we've seen that about 95% know their HIV status. This has been as a result of the lack of testing, the stockouts of the testing kits that has been there. So usually the performance at about 100% of all the women know their HIV status. Of this, we find that those who knew their status, who newly knew their status were about 8,700. And of these, those who were positive were 2,083, and about 99% were started on treatment. And when we looked at this, about 40% of the mothers who actually attended FAST ANC, as I had mentioned, were adolescent girls and young women. And the positive contribution of the adolescent girls and young women was about 18.5%. And that tells us is a big proportion of people who are of these adolescent girls and young women who require services that are uniquely curtailed to them. And about 39% of these mothers who knew their status were new positive. So not people who had been in the program, but these are patients who knew their status as they attended ANC. Looking at the adolescent girls who were new positive, you see a high positivity rate, especially in the 2024, which was at about 1.5%, and in the 15 to 19 at about 0.76%. And when we look at the age band contribution, we're able to see that even the 10 to 14-year-olds, about 0.5% of all of them were 10 to 14. 15.9% were those the older adolescents, about 15 to 19 years old. But however, the majority were those 20 to 24 years old. Of our mothers, about 439 did not receive a test, and as I have mentioned, was because of lack of the RTK testing kits. So just looking at our trends in first ANC attendance. So when you look at this particular trend, we actually see a dip looking at the months from October to March, and just looking at how the attendance in ANC for our adolescent girls and young women. What we see that in the month of December, there's usually a drop in the mothers who attend ANC. And this one we all know is mainly because of usually a lot of travels to the rural areas during that time, but also COVID-19 had an impact in the attendance of ANC. However, when you look at the distribution, both for the year, the previous year, 2020 to 2021, and also just comparing with 2021 to 2022, the same time periods, the trends look almost the same. So what was our eligibility criteria for those who are to join OTZ Plus? And as Dr. Immaculate had mentioned, then just to remind all of us, OTZ Plus just means Operation 000. And we have we have targets that we are looking at, which are 0 missed drugs, 0 viral load, 0 missed appointments, 0 missed drugs, and finally 0 viral load, meaning these patients are able to suppress their viral load. And for OTZ Plus, this incorporates a 4th 0, which is 0 mother to child transmission of HIV. So what is the eligibility criteria for this? 1, any pregnant adolescent girl and young women in the age group of 10 to 24 is eligible to join if they're HIV positive, and it is not a forced, they're not forced to join. As long as they're willing to join the club, they're always welcome to join the club. So that's all one needs to join OTZ, meaning they're pregnant, they're HIV positive, and they have the willingness to join. And so what was the process what process did the Connect project go through for us to be able to implement OTZ Plus? So as we said, initially there were we really didn't have structures targeting these adolescent girls and young women. So they were mixed together with the other population of the other pregnant and breastfeeding women. So what we had to do is come up with brainstorming meetings to discuss OTZ Plus implementation. So as a program, we involved the entire team. So the strategic information team, the PMT and the clinical team, and we're able to discuss how we were going to implement it to ensure that we had tools that we would use for reporting being available. If the tools are not available, being able to develop tools and just also use what is already existing and the EMR. As you noticed, OTZ was already there, and we already had tools, for example, the OTZ register, which we were able to get indicators for us to be able to follow up, keep appointment keeping, we were able to follow up adherence to medication, and also we were able to follow out outcomes of a mother being suppressed, and also outcomes for the infant to ensure that they do not get HIV. So the tools were there, and so we just integrated what was already there. However, we had to have a bit of input, especially the issues to do with the HIV exposed infant. Once we had done that as a program, now we needed to also sensitize the facility team. So we had sensitization meetings with all our facility teams, so the PMT teams, the case managers, the facility leadership, and just be able to bring them up to speed on what OTZ Plus is. The good thing, they already knew what OTZ was there, because OTZ was there for the other population of adolescents who were living with HIV. So once that was there, it was easy for them to adapt OTZ Plus for also the pregnant and breastfeeding adolescent girls and young women. With this, there was also cross-learning happening. The OTZ modules were shared, and again, the registers were distributed. At first, what we did was to line list all the pregnant and breastfeeding adolescent girls and young women of the age 10 to 24, and just start enrolling them into the OTZ Plus program as they came to the facility. With that, we're also able to come up with OTZ Plus specific days and ensure that on those days, only the adolescent girls and young women were booked for those clinic days, so they could have support groups, that were targeting them. And the messaging was the same. From the time they get into the facility during triage, they know that it's the adolescent girls and young women who are breastfeeding who are coming to the facility. So as they have the health talk, it is targeting that particular population. And also as they go through the clinic, they were getting the same kind of information, just targeting this population. We also were able to bring in OTZ champions who are also adolescent girls and young women who are breastfeeding. These are patients, and these are the ones who we were volunteered by the facility. This one, their roles and responsibilities was to ensure that one, we trained them on what OTZ Plus is, and once also trained them on the tools that were going to be used on OTZ Plus. And once that was done, then now we were able to, they were able to carry out the meetings within the facility. Remember, OTZ is an asset-based program whereby we use the adolescents for the adolescents. So even for OTZ Plus, it is the adolescent and young girls who are actually carrying this particular program. So I think I've mentioned the rest. And so what package is actually available? The PMTCT package that is there within the Ministry of Health is provided from the AGYWs who are in OTZ Plus. So the treatment literacy, both for the and follow-up, and just ensuring that entire package of care is provided. SRH services, including education and family planning, breastfeeding of and early infant feeding education is done, partner testing at ANC, and also just follow-up for partner notification services, CWC services, and including immunization, cervical cancer screening, GBV screening, prep for the HIV negative partners, and just linkage to the OVC program for the HAZE and also the adolescent girls who are below the age of 18. And we also incorporated the OTZ modules that we had mentioned in our previous presentation, just being able to bring up to speed on things concerning life skills. Remember, one of the gaps that we had noticed is on matters concerning life skills, leadership, being able to make decisions and planning for the future now that they even had an infant who they are living with, strengthened SRH services, mental health is there, screening for depression, screening for substance abuse, and being able also just to ensure that they get any assistance for those who are engaged in that, and just coping with transition, because these adolescents who are within the program, they were now transitioned to a different stage. Initially, they were young girls, but now they have to get into the adult clinic. They have to be able to navigate to the facility on their own and just be able to cope with the different challenges that come with having a child. Another package that is provided is for the adolescent girls empowerment, which includes child rights protection and advocacy, or training them on income generating activities, financial literacy sessions, self-image and self-esteem, patient support groups on the family, and this would also include the caregivers. Remember, one of the things that would happen with these particular adolescents as they get pregnant, sometimes their family wrangles, they are chased out of the home. And so just being able to bring the caregivers so that they're able to unite back with this adolescent and being able to integrate them back to their families, and also support them to going back to school with school re-engagement. We also be able to provide for them family planning options and just support them through education on how labor and delivery will be postnatal care for themselves and also for their child. And also, as I mentioned, just being able to speak about conflict resolution with both the family, the peers, and also the partners. So it's a wholesome package that we provide for these adolescents, and it's not provided in one sitting. They come to the facility on a monthly basis, whereby this package has been, they're able to receive this package of care until they are graduated from the PMTCT clinic. So here we're able to see our OTZ uptake. Here I have data for about 29 of our facilities as at March of 2022. We have we have about 553 adolescent girls and young women currently in care. And of these, 58% have been enrolled to care. And has been enrolled to OTZ Plus, I beg your pardon. And of these, 97% of these are active in care as at end of March. So over the last 6 months, we have had a good retention for this particular population. Here I'm looking at just comparing for our pregnant adolescent girls and breastfeeding women. We are comparing their baseline viral load and their viral load as at the end of March. So when they joined OTZ, what was the viral load? When we look at this, we had 67 who are pregnant adolescent girls and young women who were enrolled into OTZ plus. About 54% had a viral load as at the end of March. This was as a result of the commodity stockout, the national commodity stockouts of viral load reagents. That's why their viral load uptake appears low. And also, and the suppression of those who had a viral load was at 94%. When we look at now as at the end of March, of the 67, we see that 96%, 64 of them are still active in OTZ. Of those eligible for viral load, we see that the 49 who are eligible for viral load, about 55% of these have a valid viral load result, and all of them were suppressed for those who had a viral load result. So we can actually see the impact even in the pregnant women. My next slide compares viral suppression for those in OTZ plus and continuity of care for those who are breastfeeding. So the first slide was just comparing those who was looking at those who are pregnant and now for breastfeeding. We had about 251 those who are enrolled into OTZ plus. Those with a valid viral load was about 80% for those who are breastfeeding, with a suppression rate of 94% at baseline. When we come to now as at the end of March, of the 251, we have a retention of 97%, with 244 still on OTZ plus. Those who are eligible for a viral load, we have 65 of them, 65% who had a valid viral load result and a suppression rate of 97%. So we can actually see improvement in viral suppression rates and actually achieving the 95% for both the pregnant and breastfeeding adolescent girls and young women enrolled into OTZ plus. And here we're just looking at the HAY outcomes as at the end of March. Of those who are still active in OTZ as at the end of the March were 244, and of their this HAYs, the infants, HIV exposed infants who had attained 6 weeks were 171. Of these who had a PCR test within 6 to 8 weeks was 71%. This appears low, but also we'd had a national stockouts of EID bundles and EID commodities within the national reference labs. That's why you can see that low uptake of PCR at 6 weeks. However, even at 6 weeks, of those who had a result, we see those who are HIV negative were 98%. Of the OTZ mothers in HAYS who had achieved the 18 to 24 month age were 39, and of these who had an antibody test were about 37. So we had 2 who had not yet done an antibody test for, and those who had a negative HIV antibody test at 18 months were 36. So we had 1 who had turned positive. So with this, we are still also able to see that the outcomes of the HIV exposed infants of the adolescent and young girls in OTZ plus are quite good. So I also had mentioned about OVC integration. So the OVC program is our link to the community, because OTZ plus is basically a facility-based intervention. And we know that these adolescent girls and young women live within a community, and they also need community support. And so that's why we link them to the OVC program, where they're also able to get economic empowerment. They're able to get financial literacy classes, again, from the community side, and other counseling and just other services from the community. And when we look at the numbers, for example, for 15 to 19-year-old pregnant girls who were enrolled to the program, there were about 10. And of these, who were enrolled to OTZ plus were 7. And these 7 were all active as at the end of March. About 4 have been linked to the OTZ, the OVC program. So they're also able to get the community support. When we look at the pregnant women, pregnant 20 to 24, who are linked to the OVC, we have a total number of about 177. And those in OTZ plus are about 50% of this, and 93% are still active as at the end of March, with only about 12 enrolled to the OVC program, with paternal involvement of about 12%. So we still have some work to do there with linkage to the linkage with the males, and just ensuring that we also have paternal involvement for this particular, to support the pregnant and breastfeeding adolescent girls. When we look at for the breastfeeding 15 to 19-year-olds, we see there are about 37 of these. To 62% had been enrolled to OTZ+, and all of them were active in OTZ+ as at the end of March. And we can see fathers' involvement, 0. And you can just compare that for the 15 to 19, whether they are pregnant or breastfeeding, we're having challenges with involvement of the fathers. And looking at the age itself already, we can see where the challenge can be. Linkage to the OVC, about 7%. And those who are linked to modern contraceptive, about 30%. So we still have, we still need to improve on SRH service for this particular population, and also just strengthening the linkage to the OVC program. So the linkage to the OVC program sometimes is delayed because we need access, the assessment of the home. So that turnaround time sometimes may be delayed, but we are really working to strengthen this with the OVC partner. Looking at the breastfeeding 20 to 24-year-olds, this is where we have a huge number, about 377 PMT mothers. Those enrolled to OTZ Plus are about 222, and of this, 97% are still active in OTZ Plus, and we can see paternal involvement at 15%. So we see better paternal involvement for the older adolescent girls and young women compared to the younger ones. Linkage to OVC is at 52%, and also uptake of modern contraception is at 54%. So we can see better uptake, linkage to OVC, and uptake of modern contraception for the adolescent girls and young women. And this helps, this just encourages us to be able to still support those who are the younger adolescent girls and young women. As you saw in our program, we also support the DREAMS program, who are also able to empower these adolescent girls and young women, especially in the community. So our progress and current status of OTZ Plus implementation, what we see is that with CIAD Connect has been able to see a growth in OTZ Plus implementation from 1 facility in June of last year to about 29 facilities as at the end of March this year. We also have put OTZ Plus champions in the facilities so that we're able to leverage on the case management model also for this particular population. The facility staff have been sensitized on OTZ Plus, as I had mentioned. The existing OTZ Plus champions in the facilities also now continue mentoring with the cross-learning the new OTZ Plus champions in the upcoming facilities, even as we continue scaling up this particular intervention. We continue sensitizing and continue booking of pregnant and adolescent PMC clients in the OTZ clubs, and just continue ensuring that we have proper documentation so that we are able to also have proper reporting of data, and we are also able just to keep on improving on the interventions that we offer for these particular adolescents. Mentorship continues in the facilities, and for the established OTZ clubs, we are able to support them on a monthly basis, as I had mentioned, for this particular population. And for our success stories, what we have seen, as you have seen even from the data that we have shared, we have had good viral suppression for those who are in OTZ Plus, good retention among the OTZ Plus members, and also good outcomes for the HAZE with close to 0 mother-to-child transmission of HIV, even in the adolescent girls and young women. We've been able to ensure that also that these adolescent girls and young women in OTZ Plus are able to get benefit from income generating activities with the help of the OVC program. And we saw one mother who had been enrolled in one of our facility returned to college and is currently in her 3rd year of college. We've also seen family integration. As you see, we talked about with some of the things that are in the package are conflict resolution, and we've seen one mother also reunited to the grandmother, and we've seen good outcomes also for that particular family. So some of the challenges that we've been able to have is just a knowledge gap, especially on OTZ Plus by healthcare workers. And what we've been able to do is train the PMTCT team on the OTZ modules sensitization of all staff in MCH. Remember, MCH is mainly run by nurses, and just being able to sensitize them on OTZ plus, having frequent follow-up meetings, and just continuing in facility mentorship. We've also had slow enrollment into OTZ plus clubs. You see, we have a huge proportion of those who are 2024, and some of them, maybe they have work and they find that having to join these clubs may take their time, but slowly by slowly, we are seeing the benefits of the clubs and actually agreeing to join. So what we do is just routine follow-up to track the progress, health talks to sensitize the clients on the benefits of OTZ plus. We really implement the case management model to ensure that there's longitudinal follow-up of the mother-infant pair of these adolescent girls and young women in OTZ plus. And for those who refuse to join or maybe drop out, we are able to have client exit forms, and we're able to get the reasons as to why they don't want to join this club, so that we're able to try and tailor-make interventions that will attract them to these clubs. So what, as a project, things that we are looking to do are, one, just increase the enrollment. As you've seen, we are mainly currently in 29 facilities, and in total we have 51 PMT facilities. So we are hoping that by the time we get to September, all our facilities will be implementing OTZ plus. Just continue in health education for the adolescent girls and young women through OTZ plus, and targeting young fathers. You've seen in the data that we presented, for especially the younger adolescents, girls and young women, you see the paternal involvement is very low. But even for the 20 to 24, the involvement of the males is quite low. And trying to come up with a male involvement program, a way just to also bring in the young male fathers so that they're able to support these adolescent girls and young women. What we're also doing is empowering the OTZ club members on SRH, life skills training, financial literacy, income generating activities training, and just capacity build them on their roles in PMTCT. We also target the 10 to 14-year-olds with age appropriate SRH messaging. We are capacity building the caregivers of these AGYWs just to ensure that the full benefit of OTZ plus is they're able to get it, because support does not only come from the facility, but also from the family, and continue enhancing case management models and closely monitoring our outcomes. This is the EID uptake, so that in case the baby is HIV positive, they can be initiated in treatment early. However, we are targeting EMTCT, ensuring that we have eliminated mother-to-child transmission. And this is by just ensuring that our pregnant and adolescent girls, one, in case they want to become pregnant, just there's pregnancy intention assessment, especially for the older ones, 20 to 24. But those who intend to get pregnant, ensuring that they are virally suppressed, or those who get pregnant, they're virally suppressed and they are retained in care, so that we don't have transmission of HIV to the infants. Also, referral and linkages to the OVC program, just for community support, especially for the less than 18-year-olds and the HIV-exposed infants. And we continue strengthening data collection and just doing our HAE cohort analysis for our adolescent girls and young women, viral suppression and retention. But when we notice areas where we have gaps or challenges, we're able to make corrections early and ensure that our patients get the best out of OTZ plus. So here I have one slide. I just want to share with we already got consent from the one of our adolescent girls and young women who have benefited from OTZ plus. So I'd like to just share this video so that we are able to just hear from the horse's mouth. I'm not sure if you can hear the sound.
Not yet.
Share sound. Okay, now you'll hear. What has happened? Sorry, my slides had hanged. Apologies, my slides had hung and gone back to the first slide.
College, na nikatoka huku nikaenda Ushago, and I was feeling there is a time nilikuwa shule college, na nikatoka huku nikaenda Ushago, and I was feeling unwell. Nikaenda hospitali ya Ushago kwetu kupimwa. Sister mwingine akaniita akaniambia umepatikana uko na virusi za ukimwi. Sikubali, I did not agree. Niliangalia mwili wangu hivi nikasema hapana, kwani inaniuma wapi? Nikasema sasa mimi nitaambia nani? I'm pregnant na nimepatikana niko HIV positive. I was 22 years by then. But sasa ilifika mahali mimi sikuwa na meza dawa zangu vizuri. Ikaonekana viral yangu iko juu sana. Yenye waliniita hospitali urgently, wakaniambia unaenda kuachisha mtoto kunyonya. Kwa sababu usipoachisha mtoto kunyonya, mtoto ataenda kuambukizwa. Sasa mimi nikazingatia kumeza dawa. Nilikuwa na meza dawa zangu venye daktari aliniambia. Nikazingatia hivyo, kurudi tu viral yangu ilishuka. Imagine ilikuwa ADL. Na mtoto wangu kuja kupima after walikuwa wanamfuatilia. Kupima mara ya mwisho akikuwa na 2 years alipatikana ako negative. What motivated me to be a peer educator, nilikuwa naona watu wanawacha dawa. So adolescent ako viremia, adolescent amekuwa diagnosed hataki kumeza dawa. So nikaona hata mimi nilikuwa mmoja wao, na nikasema process yenye nimepitia hata mimi naweza ongelesha wenzangu, tena wale wa mama wenye wako na watoto kama mimi, naweza waongelesha ndio watoto wao wasikuje wapatikane wako positive. So meza tu dawa zako vizuri na ujipende pia, halafu tena uache stress. Ukikuwa stress free, hakuna wakati wenye utapatikana tumelala chini wewe ni mgonjwa. So stick to medication, stick to TCS zenye daktari amekwambia kama leo ni siku yako kuja. Halafu pia ustick kwa masaa. Halafu mambo na sexual reproductive health pia huwa na encourage. Kama umeanza kuwa kwa uhusiano, tafadhali tumia kinga. Kwa sababu wazazi wengine pale nyumbani wana assume. Kama mimi mzazi angeniambia tumia kinga, singepatwa na virusi na singepata mimba.
So thank you so much. I'll hand over back the meeting to the chair. I was glad to share experience.
Thank you so much for that, Dr. Ochola. That was a great presentation. And for those who are joining us, who have joined us when we were going on, today we are talking about programming for HIV-infected, pregnant, and breastfeeding adolescent girls and young women, the best practices. And we've just heard from Dr. Cornelia Ochola from CHEB on OTZ Plus. Somebody has asked what is OTZ, and it's it's Operation 000. So today we are talking about the Operation 000 Plus, whereby we are talking about 0 missed opportunities, 0 missed doses, 0 viral load, and now the plus is now the support, the programming support, and what you are doing to support these young people apart from those the 3 mentioned. So we've heard about what they are doing in the clinic, supporting these pregnant and these pregnant adolescents, and how they meet together, and it actually helps. We've seen the outcomes that have been shown. So we are going to go on to our next presentation, whereby we have David Kinyanjui. He's with us now, and he's the Casco, Murang'a County, and he's going to show some of the things that they've been doing there. For questions and comments, please put them at the Q&A section, and you'll be able to get that to the end. Welcome, David.
Okay, thank you very much. And apologies, initially I was not able to project my presentation, but also to thank the organizers for giving us this opportunity to present what we are doing in Murang'a County. So basically my presentation will focus more on the implementation, how we implemented OTC Plus. And basically this is actually focusing towards elimination of mother-to-child transmission of HIV. With me, I'm with a team from the county government and also the facility teams who are the drivers of this OTC Plus. So I think I'll start with, and probably someone to confirm that you can see my slides.
They are visible. Thank you very much.
Okay, thank you. Okay, so I'll start with this is the outline of my presentation, where I'll give a brief profile of Murang'a HIV program. Also give a bit of background on the OTZ Plus. We also look at the goal and focus now next on the implementation. We also look at the package for the OTZ Plus. Then we look at the process and outcome monitoring, and later the challenges and opportunities that exist in this program. So this is the profile of Murang'a County, and as you can see, our prevalence is actually 2.5%. And the burden of HIV is actually double the burden of female in the county is actually double that of men. So we have a higher prevalence of HIV amongst women than men. Again, our PMCTC rate is actually at 9%, and it's actually far off from the target that we have of less than 5%. And we have an estimated 20,663 persons living with HIV. And we experience around 192 HIV infections across all the ages. And in terms of the adolescents and the adolescents, the 10 to 19, we have approximately 1,054 experiencing around 24 HIV infections. And for the young adults, 15 to 24, we experience around 50 new HIV infections. Of course, this is based on the HIV estimates 2020. So the former presenter has highlighted this, that OTZ is actually anchored on the 4 prongs of PMCTC, and is actually utilizes an asset-based approach, which empowers pregnant and breastfeeding adolescent girls and young women living with HIV aged 10 to 24 years to adopt positive health behavior. So, and of course, the approach with OTZ Plus is that these women actually considered as resources with potential answers to their challenges. And so what we do is actually to empower them so that they can take responsibility of their action for their health. Like it was previously mentioned, OTZ focuses on the 3 zeros: 0 missed drugs, 0 missed appointment, and 0 viral load. But now for OTZ Plus, there's the added 0 HIV positive infants. And certainly we also have other hidden zeros, including 0 stigma, 0 condomless sex, and there are so many other zeros in the OTC, hidden zeros in the OTC program. Now, for us as a country, we started the scale up in July 2021, where we started initially with 4 facilities, and later scaled up to 16 health facilities. And we're still continuing with the scale up, where we are targeting to cover all the 41 PMCTC sites who are supported by our lead partner with CHS. Now, this is the goal for OTZ Plus. It's basically reducing the risk of mother-to-child transmission to 0, and also to improve the treatment outcomes for pregnant, breastfeeding adolescent young people living with HIV. Now, when we started the implementation, these are the key areas that we had to really focus our resources on. And the first one was the issue of HRH, where we recruited 9 OTZ champions. And these 9 OTZ champions cover the 16 facilities as I had highlighted, but they do this through a loving model, where a champion is actually attached to 2 or 3 other facilities. The other investment that we had to make was the training of these OTZ champions, where we took them through a 5-day training. The other investments was around the issue of printing of the tools, where we printed the OTZ registers and also the MIP registers, the mother-infant peer registers. We also had to prepare some adherence support materials, including phones, alarm watches, and also T-shirts and carrier bags, which were actually branded with the OTZ colors and also logo. As you can see from the top right corner, we have the 3 OTZ colors, which are actually yellow, red, and blue, with those zeros, the 3 zeros that we're talking about. So all these adherence support materials were actually blended using those colors for OTZ. And then later, of course, we had to plan for transport reimbursement. Like I mentioned, these OTZ champions are actually roving in the 16 facilities, and also support them to do the home visits and also physical tracing, especially for the high-risk pregnant and breastfeeding adolescent girls and young women. Now, this is just a graphic presentation of the steps that we actually did to implement the OTZ program. So step 1 was to identify the OTZ plus facilities. Of course, this was based on the number of the pregnant and breastfeeding mothers 10 to 24 years. So initially we started with 4 facilities. Then step 2 was to form the OTZ facility teams. And we also did sensitizations. Remember, like the former presenter mentioned, this is actually a program for the young people, by the young people. But then again, we also had to bring on board the other facility team members who are crucial to the success of the OTZ program. Now, step 3 was to recruit and now train the OTZ champions for each of the facilities, for the 4 facilities. Then step 4 was to avail the OTZ plus materials, facilities, including treatment literacy materials, the mobile phones and the alarm watches I mentioned, and the T-shirts. Then step 5 was to do a sensitization and now enroll into OTZ plus the adolescent girls and young women. And of course, this was a team effort. And that's why team effort is key, because the whole of the CCC team had to do this sensitization and also were involved in the enrollment of these adolescent girls and young people living with HIV. Now, step 6, which is also very crucial, was now to reorganize the appointment attendance for these identified young girls, so that we can now form now monthly group meetings. So now in these monthly group meetings, we have the 13 modules that are covered in OTZ plus, and of course the enrolled adolescent girls and young women will be taken through all these modules in a scheduled manner. Step 7, which is critical, is about now encouraging the members to connect with each other. And we've been doing this through creation of WhatsApp groups. So for the ones who have mobile phones, digital mobile phones, then we have put them in actually into WhatsApp groups. And then for the others who are not probably using some mobile devices with WhatsApp, then the champions, the OTZ champions, will reach them through phone calls and also do text messages. And of course, now the last and the most important aspect is that of tracking the processes and outcomes. Now, this just depicts the OTZ package, which includes treatment literacy and psychosocial support. And during these meetings, like I mentioned, we take them through these 13 modules, which mainly focus on treatment literacy. And also in these groups, we also encourage them to share their experiences, and again, also to form treatment buddies. The other key element that is discussed during these meetings is the issue of partner disclosure and also HIV testing. The other element is also family disclosure and also family testing. Issues to do with HIV prevention, sensitizing them on PrEP, GBV response, cervical cancer screening, and the issue of correct and consistent condom use. Again, we also focused on keeping the mother and baby healthy. And in these meetings, we emphasize on issues of focused antenatal care, hospital facility-based deliveries, PNC care, issues of child health services, including infant prophylaxis, immunization. We also talk to them about nutrition, safe infant feeding practices, issues of growth monitoring and vitamin supplementation. And then the whole cascade of SRH services actually offered to the HYWs. Now, looking at where we are in terms of enrollment, as of March 2022, we had 172 adolescent girls and young women aged 10 to 24 years. Out of those, we managed to enroll 141, giving an 82% coverage. Remember, like I mentioned, we started with the high volume sites, the 4 high volume sites, and then we'll be able now to scale up to the 16 facilities. Now, out of the 141 enrolled in the OTC Plus, looking at their ages, we don't have any between 10 to 14, but then 10 to 19, about 70% are 10 to 19, 81% are 10 to 24. And we just, for the ones now who are 25 years and above, the 4 of them, we are actually transitioning them now to adult care. And so, as you can see, majority of them are actually within the 20 to 24 age brackets. Now, looking at the categorization of the seed enrolled HYW in terms of the PMCTC status, 16% actually are pregnant currently, 58% are actually breastfeeding, and then 26% of them are not breastfeeding because of several issues, including some who opt to stop breastfeeding at 1 year. Then looking at the PCR tests that we've been able to do. So currently we have about 119 Hays, and of the 119, we've been able to do 96 initial PCRs for the same, with 44 getting results. And out of the 44, actually none of them is positive, all the PCRs are negative. And we have 52 of them awaiting results. Of course, you realize we've been having challenges with EID battles, and so we've not been able to do PCR tests for all these children. But for us as a county, we are happy that with support from CDC, actually from yesterday, we are able at the county level now to do EID because CDC have supported us in installing an EID POC into the existing gene expert machines in 2 of our main facilities. So going forward, we'll not be having this challenge of delayed results. Now, looking at the VL cascade, again, as you see, out of 141 enrolled, only 9% have a valid VL. And of course, we appreciate that we also been having challenges with VL at the national level. And so with the 13 OTC plus enrolled HYW, 12 of them are very suppressed and only 1 who is not vitally suppressed. So to some of the challenges, I think I've alluded to some of them, is that we have low coverage of the enrolled HYW into this. And of course, like I mentioned, this requires actual resources, so we'll not be able to cover all of them. Then again, you also have a few trained OTC champions, the issues of VL and DBS testing commodities, and also limited resources for OTC scale-up. Some of the opportunities that exist include one, increasing the road initiative for the trained OTC champions, but then again, which also require resources, and also going forward and seeing whether we can use technology to improve the coverage. And in this, we are thinking of how can we hold virtual meetings with these OTC plus HYWs, considering that going forward, the resources also being set aside for HIV programming are actually limited. So this just the picture on the right is actually was taken during the training for the OTC champions, and as you can see, these are the t-shirts I mentioned, the branded t-shirts, reading very clearly, "I'm a hero," and basically this is when we took them through the treatment literacy, and we agreed on how to roll out the OTC plans. Now, on the left are some of the screenshots made. Like I mentioned, we have formed WhatsApp groups which are actually managed by the OTC champions. And in these forums, the champions really engage the OTC plan, the enrolled adolescent girls in OTC on various issues, including disclosure, including economic empowerment. And truly, we've seen a great improvement in this area. So lastly, I want to acknowledge the Department of Health and more so the facility teams who are actually doing this great work of supporting this initiative. Again, also to thank CHS, who are a lead care and treatment partner in the county. They have really supported the county in this. We also have AIDS Healthcare Foundation, another care and treatment partner. We also have ABS Mount Kenya, who are actually our OVC partner. And we've also received great support as a county government in terms of supporting OTC Plus. And then lastly, CBC PEFA for really supporting this initiative. So with that, thank you very much. And once again, we want to thank you for the opportunity to share our experience. Over to you, Chair. Thank you.
Thanks, David, for that experience in Murang'a County. We really appreciate, and to see the progress and all the work that is ongoing in Murang'a County. We are now going to go ahead to the next to hear from some of our OTZ champions. So we have Mariam Salim with us. She's the OTZ lead in Pumwani Maternity Hospital. Karibu, Mariam. Mariam, are you able to hear us? As we get her on, maybe we could ask from our second OTZ champion, Anne Wairimu, you're able to hear us?
Yes, I can hear you.
Yes, you can go ahead. Karibu.
Okay, asante. Good morning. Good evening, everyone. My name is Anne Wairimu. I'm an OTZ champion and a mentor mother too. I was born positive and I'm currently still on care. As an OTZ champion, I support some facilities like Sabasaba, Kereaine, and Maragua. I have a child who has gone through the PMTCT program, and all the PCRs were okay. They are good. The child was negative, and the result is negative. And now she's already 2 years and above and discharged in PMTCT. And now I'm supporting some of my fellow OTZ Plus in those facilities. Some of my responsibility are I hold support groups with the OTZ plus, whereby we talk on health, we have health talks whereby we talk about family planning and reproductive health, whereby these OTZ, they need to be sensitized on family planning and reproductive health, whereby some of them, they were not in family planning, and that's why they had the teenage pregnancies. Now, during our support groups, we held support groups with the family planning nurses and whoever coordinating those facilities about the family planning. Then the other thing is we share the experiences with the young mothers. Bearing in mind, I'm a young mother too, so we share experiences on how we go through this journey on raising up our kids. And as the other mothers or OTZ plus, they give other experiences, how they go through at home, in community, and also they give challenges which they face at home. Bearing in mind they are OTZ, some of them are in school, there are those who are in high school and they haven't finished their schooling, so there is stigma and all that. Then I also do coordinate WhatsApp group where all young mothers who has smartphone, we have a WhatsApp group whereby we chat and talk more on things that we'll be doing maybe on the next meeting, when we meet in our facilities. And also, even if there is any challenge that is coming up as we wait for our next meeting, we also discuss those things. And the good thing with the WhatsApp group, whereby they find it so easy to communicate, bearing in mind there is other OTZ plus mothers who they will feel free to talk and to raise up any discussion of any kind. Some of the things that we talk in our WhatsApp group is that we talk about adherence, if there is any challenge for those maybe who have not disclosed to their partners or their relatives, whoever they stay with, about the challenges they face when it comes to adherence. Some of other things that we discuss on is about empowerment, whereby some of our OTZ plus, they have their own things that they do to generate income to be able to raise their own kids, whereby they empower even others on how to come up with some of the things that they can do to support themselves. And also, during our meetings and our group and in our WhatsApp group, we talk about disclosure. And for those who are dating the negative partners, because we have them, they give out their life experience and how they go through about disclosing their status to their partners. And also for those who are not able to disclose, we help them through our counselors, the HTS counselors, to be able to test their partners and also to help them in disclosure, whereby we see that disclosure is so much important when it comes to OTZ who are already OTZ plus, who has a kid, whereby it's a must that OTZ to give the nevirapine to their kid. So you have to be already disclosed so that you can be free to adhere to the medication, and also to be able to give your child the prophylaxis so freely without having some fears whether the partner will ask you what the drugs are all about and the kid is okay. So we talk about all those things. And then even about our young mothers on things that are going through, maybe in the facility. For instance, when there were no viral load and PCR that were being done there before, we had to, when the tests zimekuja and there are just few, we just communicate with them and tell them maybe next week we have a specific number of PCR, maybe test tools, and we communicate with them and tell them to come to the facility. And then some of the things that we do also to remind the OTZ Plus on their clinic days is that through the help and the support of the CHS with the credit, whereby we call the client, and also for those who have no smartphones, we text them or call them a day before the clinic day to remind them that their clinic, to remember their clinic day is the following day. And also we have the ushauri, whereby we have the phones that we register the all patient in PMTCT, the OTZ Plus patient also in PMTCT, we register them in ushauri so that the ushauri will remind them. It will send them a text message to remind them on their clinic day. Those are the rules, responsibilities. And then we have some of the challenges which we face with our OTZ Plus, whereby the new OTZ Plus, those that are newly tested, sometimes they feel like they aren't fitting anywhere. And then sometimes when you join them into a support group, they are just like, the others have already adapted and they are okay. And then the new client is like, are you sure whoever is in this group is HIV positive? And then before they fit in the group, we have some challenges, but we walk through with them to help them to be able to join others and feel free. And then the other challenge is that the disclosure for those who are newly tested, bearing in mind some of the time that we capture those OTZs, they are at ANC clinic, whereby they come and then they are tested and then they be positive. And then we tested the OTZ, now the girl, and now we don't have the partner. Now disclosure and adherence becomes an issue because even that girl hasn't accepted the result, there is the denial, and then we face some of them, the defaulting, and then they aren't ready even to start, and the fear of, what if I tell my partner and then ameniacha, and then how will I raise the kid alone? Some of the issues that I don't want to lose the guy. Maybe he's the only one who can support me. For instance, for those who stay with their grandma, so they see that the partner is their only support. But now we have to go with them the journey and tell them the advantages of disclosure and the support that come out with the disclosure. And then bearing in mind the OTZ, that those ages from maybe 10 years or 15 years, those who have babies or they are pregnant and they are breastfeeding, some of them, they are just naive. So some of the things that they are doing, they're just, the age and it's bearable, but they're just naive. So those are some of the challenges that we face as we go this journey with the OTZ Plus, but we are still doing good. Currently, in our OTZ Plus, there is no a mother who has infected the kid. We are good. Some of the advantages now of having the OTZ groups and the OTZ Plus group and discussions is that it reduces having the positive infant in our facilities, because there will be support for those mothers, and we'll go the journey with the mothers, showing them that this is how we do it to have a negative kid after all. And then the other thing is the other advantage of having an OTZ mentor in an OTZ group is that through the OTZs, whereby the other OTZ Plus, the other young mothers will be able to open up on things that they are facing and the challenges that they are going through, maybe raising their kids, taking their medication, or even giving the kid the prophylaxis. that's where, as we talk with them, we in support groups and in WhatsApp, they are able to even open up and tell you what are the challenges that they are facing. And then the other advantage is that it helps in bringing to board all the young mothers together, thus they will feel free even when at facility level, whereby when you give them a specific day of a clinic, that day it means that it's an OTZ day. Bearing in mind, in the PMTCT clinic, there are even those older mothers, they are 50 years, 40 years, 40 something years. And then when you give them a day, combining them with the old mothers, those young mothers won't feel free and they will feel misplaced. So advantage is that when you give them a specific day, they will feel free even coming to the facility. They'll know that when I go to the facility today, I'll find someone that I know, someone my age. No one will like discriminate me. I feel like I'm mi ni mtoto sana nikiwa kwa line, something like of the sort. And then even in the support groups, you have to be specific that the support group for the OTZ, for them to feel free and be able even to talk with other OTZ, and then they don't feel they are just alone. And then the other advantage is that the OTZ plus, it will bring up the good environment, even with the OTZ, whereby other OTZ will even discuss on some of the family planning they are using and they are okay with them. Because even in our support group, we talk, so the OTZ chat so much and they just ask some of the questions. And even you feel like if in that WhatsApp group there kuna those people that they can judge them, hawawezi ongea, but wakifeel wako free and everyone is understanding them, things will be flowing the way it should be. And that's all my presentation for now. Thank you.
Thanks so much, Anne, for that feedback and all the good work that you're doing at your center and holding up the OTZ plus group at your place. We've learned a lot from what you've said and from the things that you're doing. It's a really positive feedback and we really appreciate. I'll just give a chance to Mariam, if she's still in, to give us briefly from the Pomoni Maternity Hospital. Are you able to hear us, Mariam? Since we are not able to get her, but we have gotten at least from what Anne has shared. Anne has shared, she's an OTZ champion, and she has been able to share about what they're doing at their centers. We're now going to give a chance to, we have some of the professionals with us here, and I'd like them to comment before we do a round of final comments from our main presenters. Maybe Dr. Odula, if you're in, would you like to comment on the sessions?
Good afternoon, everybody. Yes, there's very beautiful presentations, and I totally appreciate the actual input from the champions on the ground. And yes, I did note a comment from Professor Lema saying that we have to do the preventative measures first. So well done, and continue doing what you're doing. Thank you very much.
Thank you so much, Dr. Odula. She's a reproductive health specialist and has done a lot of work in this area, and we really appreciate you. Dr. Pamela Godia, would you like to comment on the session? Maybe later we'll get up. Right now, we'd like to give it to Dr. Immaculate Mutisia. She's the one who's put behind all these presenters. She comes in from CDC with a lot of experience, and we'd like you to also hand over to you to give some comments and maybe some of the answer some of the questions as you also go around the panelists to just give their final comments and answer some of the questions. Dr. Immaculate. Dr. Cornelia, maybe you can go ahead.
Thank you so much for the opportunity to make this presentation, and just also to have my fellow panelists. I think I'm looking through the questions, and I agree that definitely having prevention is the initial step, and this really begins from our young mothers who attend ANC. As you see, majority of these are HIV negative, and just ensuring that we're able to assess those who are high risk negative, meaning they're high risk to getting to being because of their either practices or where they are at, they're at high risk of being HIV positive, and just being able to ensure that we link them to programs that are able to support them. For example, in Nairobi, we have the DREAMS program, which is able to support the vulnerable adolescent girls and young women, and just ensuring that they're able to get preventative messages, and just ensuring that they also don't get, they're able to be protected from getting HIV. Another thing is also just ensuring that pre-exposure prophylaxis is given to those who are at high risk because of they're at high risk of being HIV positive, and ensuring that they're also protected from this by ensuring that they're on pre-exposure prophylaxis, being on PrEP. But definitely handling adolescents is not easy. Looking at our data, we see it's not perfect. For example, when you look at our 15 to 19-year-olds, we are able to see gaps even in the community before this young adolescent is able just even to disclose that they are pregnant. Most of the time, there is no involvement with the male partner. They have been thrown out by the family. And so here from the facility, at least they're able to find a place in OTZ Plus where they belong, and they're able to meet with other adolescents who are like them, who run the OTZ Plus program, and they're able to support each other and have positive outcomes, and not only health positive outcomes. You've heard about other ways where they're also able to have positive outcomes for those who are able to go back to school, for those who are able to come and have income generating activities, and they're able to take care of themselves and also their children. And so this is definitely a journey, but this is a step in the right direction. OTZ Plus is definitely a step in the right direction, and not looking at these adolescents as problems to be solved, but generally looking at them as solutions, knowing that they're able to provide solutions that are unique to them and are able to provide positive solutions, and just to support each other and ensure that they do well through the OTZ Plus program. So thank you very much. And thanks to the entire team. This cannot be done by one particular team. Definitely the teams from the facilities, the team from the communities using the OVC program, and also support from our partners. So thank you very much, and I'll hand it over. Thanks.
Thank you so much, Dr. Ochola, for that. Actually, it has also summarized some of the questions, and I see some have been answered in the presentations. There are very positive feedback here, very unique programs with positive impact. What are some of the challenges that have been faced and the modalities? This has been mentioned, and even hearing from the OTZ Plus champion. Somebody with a comment, I would recommend on increased sensitization on contraceptive counter on myths and misconception. We need support on continued efforts to faith-based organization to embrace chance and condom as contraceptive to curtail stigma. Sure. We reach out to people who do not come to hospitals, specifically who visit pharmacies in communities. So this is a question on the reach. Maybe David will answer that on some of the programs that you do. How are we able to reach those who do not come to hospital, and also ensure that also those who are in the private facilities are able to benefit from these programs? Maybe David, you can go on that.
Okay, thank you very much. Once again, I want to appreciate all the presenters. We've really seen some very nice best practices. And from the questions, I see a question around the sustainability of the program. Yes, for now, as county governments, we've been supported by implementing partners. But I think these are very crucial interventions that will go a long way in helping us as a country and also as a county to eliminate mother-to-child transmission of HIV. So I want to confirm that yes, as county government, we are really keen to make sure that we follow up these interventions, even as donor funding dwindles going forward. Now, the question around what you're doing in terms of those who do not come to hospital. For us as a county government, we are really invested very much on community strategy, and we have our community health officers who man the various community units, and they're really supporting us in terms of making sure that if we have those clients at the community level who are not able to come to the facility, they actually follow them up and are able to be linked into care in our facilities. So I think from my end is to really appreciate the organizers and also to appreciate the other presenters who really shared a lot of what they are doing. And I think overall we can actually learn from each other. I also saw someone ask about the private sector. Just to confirm that for us as a county government, when we rolled out OTZ in 2018, we actually made a benchmarking visit to the Mater Hospital, where they have a very progressive OTZ Plus program. And we really learned a lot for us now to start implementing the same in our county. So I want to stop at that and thank everyone for the support. Thank you.
Thank you so much, David, for that. Yes, somebody asking about children. We'll have a pediatric session, HIV session with the team in about 2 weeks' time on the same. And just as a very last comment to our question, Dr. Ochola, if you could just comment on this, on the Mentor Mothers program. So this Fidelis Wamala asking, this looks like a reinvention of the Kenya Mentor Mothers program, which, if not wrong, has a reporting tool like the DHIS2. I would like to know how reporting is done. Just a final comment on that as a wrap up.
Thanks, Fidelis, for your question. Why OTZ Plus came about was because we are having adolescent girls and young women who really did not fit in with the other adolescents. So they stopped coming for OTZ Club, which is a patient psychosocial support group targeting adolescent girls and adolescents living with HIV. And also for PMCT, they were not attending the PMCT support groups. Why? Because they felt they did not fit in. So this is a solution targeting mainly the adolescent girls and young women, whereby we are able to reach out to mainly this particular population. And one, the Kenya Mentor Mother program has been a very good program, and we're able to learn through such programs so that we're able to come up with interventions that will now also reach other subpopulations, not only the general population. And what you'll also realize is some of the interventions that are there for the general population may not fit in completely with the adolescent girls and young women. And so the OTZ Plus. And OTZ Plus was actually developed by adolescents and young people. So as we said, it's an asset-based model, whereby we're able to actually work with the adolescents to come up with a program that would work for them, of course, with guidance from the larger team. And that's how OTZ Plus was birthed. So OTZ Plus is not in the DHIS program, DHIS2 as yet, because it is not within the MOH as yet. But I know with time, just as OTZ began slowly and has evolved over time, that now whenever you go to any HIV, any CCC or any area where they're implementing HIV programming and you talk about adolescents, OTZ is the first thing that comes to mind. And we are hoping that now that also for the pregnant and breastfeeding adolescent girls and young women will have the same effect, that OTZ Plus is going to have such an impact and a positive impact that we're able to see positive outcomes in this particular population. So thank you so much for your answer, for your question, and I hope I've been able to respond.
Thank you so much for that response. Yes, indeed, in time, it's going to be part and parcel of the programming that is ongoing. We really appreciate your time. To our main presenters, we really appreciate you being with us and giving us all this information. To our participants, thank you for staying with us till now. You're welcome for our other sessions. We're having a session tomorrow on gynecological series, on cancer session. You are welcome. And also for this, we'll have another session like this one, a HIV series session, where we'll be focusing on pediatrics, and we'll let you know about that on the exact date for that. So we really appreciate you. We've come to the end of this session. Have a good afternoon, rest of the afternoon. Thank you.
Thank you very much. Good day, everyone.
Thank you.